I think first time we have an issue like this. Anyway, we'll see. Okay, good morning, America. Good evening, India. This is Sean Shankaran, General Secretary, Indian Overseas Congress. Today I have Dr. Tulsi Raj Ravila, Director, Aravind EyeCare System, Madurai, and also Dr. Amalur Nathan from Chennai. So, who's also part of the Tamil Nadu Planning Commission. We are having an August audience with the help of our friend Gandhian Balasubramanian Muthusamy. Without much ado, I'll ask Balasubramaniam to give an introduction, and then I will let the presentation continue. Sam has some difficulty. Oh, I think Sam is here. Okay, Sam is here. Okay, finally.
No, I think there is something wrong with my laptop. I had to reset it.
No issue, Sam. So this is our 43rd week, Sam, and we are finishing 1 year.
Welcome, sir.
We are finishing 1 year with this today's session. Out of 53 weeks in this last 1 year, out of 53 weeks in this last 1 year, we have finished 43 weeks. Despite you were traveling along with Rahul Gandhi through Europe and a lot of things, we have missed only 10 sessions, which is very amazing, really amazing.
Well, thank you for both of you, Sean and Premvada, for doing this. It wouldn't happen without two of you. Thank you, Sean, for the leadership. My apology for being late. I want to welcome our guest today. I'm delighted that Bala and their colleagues have been able to join. Earlier, I thought we'll talk a little bit about US elections, but let's not spend time on this, and let's go on directly to the topic we are going to be discussing. I'm aware of the good work Aravind EyeCare has done. I know a lot about it because we are all proud of their long journey and the contribution they have made to Indian society in general. They do millions and millions of these things at a very low cost, and there is a lot to learn from them. So I'm delighted that they are here today to tell us a little bit, especially to our younger people, that some great work is going on in India. And it is not in the last 10 years. It has been going on for decades. And all of these people have spent their life serving the nation. Unfortunately, very few young people know about these things. So I'm thankful to all of them. I want to hear more about their work, and I want our young people to get inspired with the kind of quality work they do at a price which is unthinkable in America. So with this, I want to welcome you all. And Bala, I believe you are going to take the lead. So I turn it over to you. Thank you.
Thank you, Bala. Go ahead, Bala.
Yeah, thank you,
a
Mr.
quick introduction about Dr. Tulsi and then Mr. Tulsi, and then we'll take it from there.
Yeah. Mr. Tulasiraj Ravila is an alumnus of Indian Institute of Management, Calcutta. He joined as an administrator of the Aravind EyeCare Hospital in 1981. He is currently the Executive Director of Lions Aravind Institute of Community Ophthalmology, as well as the Director of Operations for Aravind EyeCare System. He is the founder president of Vision 2020, the Right to Sight India, and the board member of Seva Foundation. He represents many national and international advisory committees on EyeCare, and he is the president of Aro Lab Trust and past trustee and treasurer for Dhan Foundation. He is a visiting scholar at University of Michigan. And with this few words, let me hand over the presentation to Mr. Tulasiraj Ravila. Welcome, sir.
So thank you very much. Thank you for the very kind words, Shri Sam Pitroda. It's been an honor to share the stage in your presence. So I'll go ahead with the presentation. Hopefully my slides are visible. I'm new to this technology of using stream video. So just want to check, Shan, is my slide visible now?
Very well.
Yes, sir.
Yes, it is.
Yes.
So, as Mr. Pitroda mentioned, I'll be talking about our work, which is essentially tackling one of the many social problems, the one of people being needlessly blind. Now, that is people whose loss of vision or vision impairment would have been either easily treated or prevented. So all of this started in 1976 by our founder, Dr. G. Venkateswamy, who is sitting there. This started in a very small way in a rented house. The others that you see are part of the starting team, including me standing in the rear. So our founder, Dr. Venkateswamy's vision was one of having a world where there is no one who is needlessly blind. And then that's what led to the purpose of eliminating needless blindness. And we recognized that this has to be done in a very innovative way, because many people won't be able to afford the care that will be given. So we have to make it affordable to all, which would mean that for many, we would have to provide it free. And then for a significant number, we will have to also spend money to have them access care in addition to providing it free. So let me start with a story of Sambavan, who is no more now. When we had organized a camp, he showed up, and he was a beggar because he was blind in both eyes due to cataract, and he was eking out a living by begging. So in the camp, it was diagnosed that all that he had was cataract, and a simple surgery would restore his vision. But in those days, we offered the surgery for free, but we requested the patients to come to the hospital on their own, and we also said that for the 1 week that they had to stay in those days, they would also have to feed themselves. Then Sambuan was very thankful. He blessed us, but he also said, it's my fate that I'll have to live like this and die like this, because unless I beg, I won't be able to feed myself. And if I'm in the hospital for a week, I won't be able to beg and get money from others, which means I wouldn't be able to feed myself. And this was very revealing to us, and it also kind of helped us look at our own earlier eye camps, where we used to recommend several people in the course of a year in those days, probably a few thousand people to come and undergo surgery. And we had realized that very few people had actually come for the camp. So this kind of triggered our thinking that we are not doing something right here. So we did a study wherein we basically pulled out 100 case sheets, where the patients had been advised to undergo surgery. We tried and to make them went to their homes. We were able to find 82 patients. And we tried to find out whether they got operated or not, and if not, what the reasons were. And what this analysis showed us, or this research showed us, was only about 15% had surgery. And then we were intrigued because all these people had voluntarily come to the camp seeking help, and we had diagnosed them and offered free treatment. So that we looked at those who did not come, and what we basically found was that all of them were pretty much blind. Then more, and what intrigued us was that most of them actually wanted to have surgery. So this was puzzling, and when we dug deeper and asked questions as to why they didn't undergo the surgery, what came out was that it was basically a socio-economic reason. Now, quite a good number did not have the resource for transportation or paying for the food, etc. And then another significant number also had a lack of family support, because we know in the Indian cultural context, if an elder gets as a medical problem and especially a surgery, it is expected that someone in the family accompanies them. And that was becoming a problem, because they, in that social strata, if someone doesn't work, they don't get to eat that day. So this gave us a big realization that us not charging does not mean that the patient doesn't have to spend any money. And with this, it led to a redesign of our services. So we recognized that in order to make care affordable, we not only have to provide free surgery, but we also have to provide them free transportation to the hospital and back, as well as feed them when they're in the hospital. And that became part of the offering. And then to overcome the social barrier of someone having to accompany them, we told the people saying that we will take full responsibility of taking to the hospital and bringing them back to the campsite a week later after the surgery is done. And then we also invested in counseling so that the fear and other aspects were addressed. And this redesign literally worked like magic. The very first outreach camp that we organized with all of these ingredients in place. And of course, we didn't have the financial resources to do all of this. Now, but then we were able to approach the community and mobilize funds for doing this. So in the very first camp that we organized in a place called as Karur, we had one busload of patients showing up around 5:30 or 6 in the evening. And the bus conductor said, "Sir, there's another busload coming." And we were very happy that this is actually working now. And then when the second busload came, the conductor said, "Sir, there's another busload coming," which was more than what we anticipated. And we finally ended up having 4 busloads of patients, about 250 odd patients coming for surgery. So this was a great insight that we had. And then we recognized that same thing also applied when it comes to glasses. If we gave them only a prescription, then the patient had to go to the nearest town to place order for the glasses, and then actually make maybe 2 trips, sometimes 3 trips to get the glasses. So we came up with a way of delivering glasses on the spot. Unfortunately, the video would not play. Otherwise, you could have seen how it works. When we studied the impact of these 2 methods of working, what the research showed was that if we gave only a prescription, 3 months down the line, only 25% of them were actually wearing the glasses. But on the other hand, if you gave the glasses on the spot, in both instances, they pay for the glasses. It's not given for free. About 80% of them were actually wearing the glasses. We basically eliminated the entire cost of procurement, which in most cases would be actually more than the cost of the glasses. So this video I don't think is going to play. We do the refraction to find the prescription for the glasses. And then we take an inventory of lenses and frames, and based on whatever frame they choose, we immediately fit the correct lens to the frame and give it to the patient. All of this we're able to do in about 25-30 minutes. With the result, the patient can actually try on the glasses and make sure the quality is appropriate, and then they leave with the glasses. So this is so the major insight that we had in this was that providing services is not good enough, even if it is for free. We really have to enable the patients to access it. But this we recognized requires want to own the problem, and we'll also have to redefine the boundaries. And otherwise, usually hospitals and healthcare providers feel that their role is to do the diagnosis, prescribe treatment, and then if someone is willing to undergo the treatment, they would carry it out. Otherwise, it is all expected to be the patient's responsibility.
We lost you.
Yes,
Tulasi,
we have.
Tulasi, are you there? We have trouble hearing your audio. Mr. Tulasi?
Maybe he put
And
us
towards that,
by mistake.
Yeah,
Yes,
we
back.
got
He's back.
Yeah,
Okay.
we got it. We missed maybe the update what you were sharing last, maybe.
you lost some of my input, is it?
Yeah, correct. Audio.
Yes.
Okay. I'll
About 2
was it
minutes
in
of
this
your audio.
About just this slide.
Yeah. This one.
Last
slide?
slide.
Okay. Thank you for flagging this. So the insight that we had with that kind of process was that providing services even for free is not good enough, and that we had to actually enable the patient to access it. And to do this, we also recognized that we had to own the problem, which typically is not seen as the hospital's problem. If a patient did not come, most providers would feel it is the patient's responsibility. So which really required that we redefine the problem and own the patient's inability as our problem and not just pass it off as the patient's problem. And I think that DNA shift helped us help the community overcome these issues. The second realization that we had was that not everyone with poor vision is able to seek care. So our focus was on people who are not seeking care, or what I'm terming as the non-customers. Towards that, what we did was to organize eye camps from day one, which is not uncommon. And then by 1999, this whole process had matured. And in a year, we would organize about 1,500 to 2,000 such eye camps. We were seeing more than 400,000 patients. And the number of surgeries, cataract alone was 80,000 plus, and overall maybe 100,000 surgeries were done through these outreach activities. But having done this, we were not sure if this would be adequate. Am I still not audible?
You are.
You are
Okay.
good, sir.
Okay, thank you. So we were not sure if this was adequate. So we asked this question if this was good enough in reaching everyone, in the sense, will it help us achieve our purpose? So we did a population-based study to find out if the camps were used by everyone who was in need of eye care. And what the study showed, what this is done quite scientifically with the help from London School of Hygiene. And what the study showed was that less than 7% of those in need of eye care in the eye camps that we did were actually came to the eye camp. And this was quite a revealing number. We knew it won't be 100%, but we did not expect it to be as low as 7%. With the which meant we're not even scratching the surface, and this represents less than 0.25% of the population. So we had to completely redesign and do something to supplement this. After several years of experimentation, almost it took us 4 or 5 years since we did the study to come up with the intervention. which was setting up in the remote areas technology-enabled primary eye care centers. We initially tried working with Dr. Ashok Junjunwala. I think Mr. Pitroda will recognize that name.
Of course, he's a friend. He's a good friend.
Yes. Yeah, and that time the bandwidth he could provide was only half Mbps, but we wanted a much higher bandwidth for smooth video, for live video conferencing. So that time, this was in the early 2000s, when the internet was limited to very large cities. Only even Madurai did not have adequate internet. So we put up our own towers and we used Wi-Fi, which was an open source spectrum, to go long distances. And we were able to get about 4 or 5 Mbps speed, but we had to put up our own towers, which we did. And we established the first set of primary eye care centers, which were situated in small rural towns where there is no eye care anywhere in the near vicinity. And it was completely paperless. We also built an electronic medical record, which was in the cloud, but the language was not there that time. So because we wanted the record to be accessed simultaneously by the base hospital. So again, the video wouldn't work. The way it works is a patient walks into the clinic, they pay 20 rupees, which is good for 3 visits. A complete eye exam is done by a well-trained technician who has had about 4 or 5 years experience. All the findings are entered into the electronic medical record, and the investigations and what is done is similar to what they would be done in an eye hospital. And then there's a live consultation with the doctor where the technician presents the findings. The doctor clarifies it, then the doctor talks to the patient with the diagnosis, and then whatever is a prescription, medicines or glasses, is sent by the doctor, which gets printed out at the primary eye care center. And then in the center, we have provision for giving the glasses and the medicines. So this whole cycle takes about half an hour, 45 minutes, and completely eliminates the need for the patient to go to the which was the nearest town. You know? And then today we have a network of 117 such centers, and the last year we had close to 1 million consultations, million visits by patients, and that many teleconsultations, resulting in 54,000 surgeries and more than 100,000 glasses being dispensed. And then what was very interesting was that because of the earlier experience, we started tracking very closely the population coverage. The 113 centers which were there, the data is till March 24, covered a population of about 12 million. And of the 12 million, we had 3 million people register and get eye care, which relates to 25% of the population, which is literally 100 times more than what the eye camps were doing. So this has been a significant which we are propagating to beyond ourselves. You know, we are promoting this to other people. And then the insight out of this was this relentless pursuit of focusing on needless, those who are not coming to us, the non-customers, is actually a market building exercise, you know, and not competing. Because if you're competing for existing patients, then we are not moving the needle. You know, whether we provide care or somebody else provides care, care is given. But it is those who are not accessing care are the ones that we have to target. You know? So, and this has helped us by growing the market. We also get to serve. We get the first pick or no of those who are entering the market. The third aspect is how do you do a patient-centric design, recognizing that the patient has got multiple costs involved. Lost wages of them, the accompanying person, etc. This is not only those coming to the camps, but also the ones coming to the hospital. So our goal was to see how do we minimize this. So the service design that we came up was that for the patients, there would be no appointments. And this is a significant cost saving, which means that because eye care or eye problems for most part very gradual onset, so it's an elective kind of a procedure. So when there is no appointment, they can come to the hospital. When they come to the town for some other activities, for a wedding, for shopping, they can just add on to it. Otherwise, they'll have to make a visit specifically for the hospital. But you can also imagine in the late 1970s, telephone was a huge luxury. I had to wait for 4 or 5 years, and Mr. Pitroda changed that whole scene when he brought in the CDOT technology. But otherwise, making an appointment would be quite expensive. They had to make a personal visit and so on. But in spite of not having appointments, we figured out to provide care without any waiting list, either for outpatient consultation or for surgery, which again you'll find is dramatically different from what happens in US, Canada, or UK, where the waiting list could be months on end. And then we also designed it so that the entire care cycle, including cross consultation, everything can happen in a single visit, including surgery if the patient is willing to have surgery immediately. And also provide care at the appropriate level, because we had primary eye care centers, secondary and tertiary centers. And we also gave the liberty to the patient to choose to pay or not pay. In the sense, if they came to the paying section, they would pay. They went to the free section, the entire professional services was for free. And then there was no gatekeeping for this. So that was the design. And then on the hospital side, what we did was to manage all this, we came up with a fairly good predicting model, by which we're able to predict how many patients will come on a day. And it's fairly accurate. We are off by less than a 5% bandwidth. And we focused on efficiency and quality, because all of this reduces overall effort. And we also innovatively manage bottlenecks. I'll give one example of this. If there is one surgeon who has one operating table supported by one scrub nurse, and if the surgeon had only one set of instruments, even though the surgery takes only less than 10 minutes, the surgeon can perform only one surgery per hour. But with the same surgeon, if you added another table and gave another support clinical staff, a scrub nurse, and a few more instrument sets, the same surgeon can do 6 to 8 surgeries per hour. So, and then again, this video would have explained it, but you can see the way it works. There are 2 tables, and then on one table, the surgeon is operating. On the other table, there's a nurse. You can only see her hand, but then she's getting it ready to get the next patient to come. And by the time the surgeon finishes this, the surgeon just swings the microscope over to the other patient. And we position the microscope in a particular fashion, by which we also minimize the effort required for focusing, etc. There's no need to shift the microscope, just the arm swings over. And then the surgeon starts operating while the nurse on this table would finish up the bandaging, etc., remove the patient, and bring in the next patient. So by this back and forth, we basically eliminated the time between the 2 surgeries, and that has led to increased productivity. And then the doctors are the bottleneck resource, in the sense they are the most critical resource, and good management would say that you shouldn't keep an idle resource, a critical resource idle. So this way of reducing cost and effort, I think, is driven when you are able to have things from the patient's perspective, and that requires a certain element of empathy and compassion to drive this. I'll touch on a couple of mindsets, which again has helped us, because we have to recognize that all of us operate under constraints, and then we can either complain or figure out how to do it. So some examples of how we figured out. When we started out, we had ophthalmologists, not enough, few, but then there was zero support staff. There were no courses, or even today it is just falling in place. Even today it's a struggle. So initial days we used to take some village girls and organically train them literally on the job, 4 or 5 girls each year. But over time, this program has grown, and today we take 600 to 1,000 girls every year, from the areas around the hospital, and they undergo a 2-year training, because we recognize that in caregiving, whether it is ophthalmology or any other place, significant amount of it is repetitive skill-based work, which doesn't require 10 years of medical education and specialization. So we did a lot of task shifting, with the result that close to 80% of the touch points of the patient are done by these young women. And since each of them does only 1 or 2 skills or tasks, the quality of that work is far superior than what a well-qualified doctor would be able to do. So these are repetitive, skill-based routine tasks, while the doctor is reserved for doing the more advanced things like surgery or diagnosis, which requires a tremendous amount of medical insight and knowledge as a background to interpret all the results. So everything that is measuring, as you can see here, power of glasses, pressure of the eye, or imaging, all of that is done by this staff. The other innovation that we did recently was that in order to prescribe glasses, you need to find out what is the refractive error. And that again is a very specialized skill, which would take about 2 years of training. And then there are not enough training places, or once trained, these people are not very happy to work in rural villages. So we worked with MIT and Harvard, their media labs, and then we developed this equipment which looks like a binoculars called as EC. That's a brand name that we are given, where the patient just has to look into it for 20 seconds. Nothing else is required. And then using certain technologies of aberrometry, your prescription gets generated of what glasses they have to wear. And this has been validated. And this pie chart actually had some numbers, which is not visible, basically saying that this is as good as someone with 4 years of training giving a prescription. So literally, this machine-generated prescription can be given to an optical shop, and they can get the glasses. Or more recently, we worked with Google, wherein we would upload the retinal image, and that would get interpreted in the cloud, and then we would get a report saying that whether the patient has got a diabetic patient, whether they've got diabetic retinopathy, and if yes, what stage is it, should they be referred or not. And that has been incredibly powerful, because we are now able to bring the expertise of a highly skilled retina surgeon to the primary eye care centers. And of course, there's always your overriding filter on that, because that is again seen by the doctor providing the teleconsultation. And then we are now able to not only diagnose the diabetic patients, whether they have retinal problems or not, but also follow them up at the primary eye care centers itself. And then another innovation was that in the late 1980s, for people who had cataract surgery, some of the audience might have, the current practice is to implant a lens. But till the late 1980s, the standard surgery was to remove the human lens, which is the cataract surgery, and then give the person a thick glasses like this the elderly gentleman is wearing, to be of power of +10 or +12, very heavy. And then the quality of vision was not so great. But then the problem was these lenses cost about $150 to $200 then, which was far beyond the reach of an average Indian. Even a middle-class Indian couldn't afford it. The result, very few surgeries with a lens implant was being done in the early 1990s. And our efforts to bring down the price, we thought $10 then would have been appropriate. But that was not within the negotiating bandwidth. $150 to $10 was a huge difference. Then we decided that after doing a lot of research, and we took the bold decision to set up our own manufacturing facility, which was again set up as a not-for-profit entity. Today, Aurolab makes, and then when we introduced the lenses, we made a 10x price disruption, and then offered it for $10. And interestingly, we made some profit at best, even at that low price. And today, Aurolab is a significant provider of lenses globally. And we estimate that we probably have about 12% of the global market by volume. We pretty much cover all the developing countries in Latin America, in Africa, and in Asia. But we are not present in the more developed economies like Western Europe, Pacific Rim, or the North America. So this has been another insight that we need to build organizations that are self-reliant and with a can-do attitude. And again, we felt that our purpose was a big driver of this purpose as well as the values. I'll skip this because this is a video which will not play. So I'll just briefly go over the impact. What started in '96 with 11 beds over time has grown into 7 large hospitals, with each hospital seeing 1,000 to 3,000 odd patients every day. 7 smaller hospitals, what we call as secondary care centers. 7 clinics that are run by doctors, and 117 primary eye care centers. So today, on an average day, we see more than 20,000 patients across the system. We do between 2,000 to 3,000 surgeries, lots of outreach work. And then we have a very robust human resource pipeline. So we do a lot of training for doctors, technicians, and administrators. Last year, we handled more than 6 million outpatient examinations, performed close to 730,000 surgeries, close to 900,000 glasses dispensed, with half of the surgeries being provided either free or steeply subsidized. To give a perspective of this volume, this may be equal, I'm not sure of the current numbers, or more than what is done by all of NHS in the United Kingdom. And our area of operations is essentially Tamil Nadu and the bordering states of Andhra Pradesh. And we have continued to grow over the years, probably because of this approach, excepting during the COVID period when everybody took a hit. Another thing that we have done is to share all that we have done, because the purpose was to eliminate blindness worldwide, and clearly we are not going to do it by ourselves. So we felt it is appropriate that we share it So we came up, and we do this very proactively. We set up an institute in 1992 with adequate faculty. We offer 45 odd courses, structured courses, for providing specific skill development, as well as long-term training of ophthalmologists. Over the years, we have trained close to 13,000 people in countries. In addition to that, we do consulting, wherein the difference is that the clients don't pay us. We raise some grant money for doing it. We have worked with about 370 odd hospitals across 29 countries. Through this initiative, we have added to whatever they're doing earlier on about 800,000 surgeries annually. So that much additional eye care has happened through our input, but of course, all the work is done by these partner hospitals. We are also very actively scaling up the primary eye care centers, which we found to be very effective. And we set a goal of creating access to 1 billion people. This is just our own internal goal and nothing that we will take credit for, because it's more of a movement. We were able to convince the Bangladesh government, when the previous government was there, Sheikh Hasina, she became a strong advocate of this, and then established more than 200 vision centers in Bangladesh. Along with other agencies, we have 235. So today we estimate that we are possibly around 25% of this 1 billion mark that we had hoped to do it. And we are under no pressure to do it other than the pressure that we bring on internally. We've also been pretty robust in publications. I want to conclude my talk with a few slides, because I think doing what we have done, we also have to build the DNA of the organization. It's not just about the systems and processes. That we felt falls in place with conflicting, self-imposed conflicting principles. I just explain what they are. One of the conflicting principles is that we had to do high or be highly productive. At the same time, we said we will not pay for performance, which is the typical paradigm. If you want higher productivity, you have to pay for the productivity. But we didn't believe in this, because a lot of the productivity is on the free patients who are not paying us anything. So what we focused was on drivers of productivity. So we recognize that if you want to be highly productive, you also have to have a high patient flow or demand. Now you require skilled support staff, which we put in place. We require robust, flawless supply chain. To my knowledge, we have not had even one surgery get postponed because we did not have a lens or appropriate medical supplies. All equipments have to be functioning. Enabling work environment where there's no frustration. So all of this actually contributes to productivity. Now, with the result, what we have noticed is that the productivity in Aravind far outstrips what is there in other countries. The other tension that we worked was that how do you solve the blindness problem when most patients can't pay? But we also put in another counter, non-negotiable, that we will not raise donations for our work, for the core work. We'll of course accept people if somebody is moved to give us some donation, but then we don't have any formal program for raising money. So to do this, what we did was to focus on what would bring in patients and the revenues, which is good quality, good outcomes, good patient experience. When you deliver this, you automatically get patients who are willing to pay, which means your top line gets taken care of. And when you focus on efficiency, optimal use of resources, and then have a culture of frugality, your costs go down, and then that impacts on your bottom line. And then we are, as you can see, even though we are a non-profit, we have a pretty healthy EBITDA, which may be the envy of many for-profits. But all this supplies, all the hospitals, all the expansion is funded by this annual surplus that we make. The third tension is between quality and volume. In the service sector, this has been difficult to achieve in pretty much most sectors. If you want high volume, then there are compromises to quality and experience. So to address this, we focused on what drives quality. I think the starting point is the quality mindset, having the right resources, right processes, and then good monitoring, which means good documentation, feedback, etc., resulting in continuous improvement. And what this has resulted in is that if you look at visual outcome, our outcome of persons who can see normal vision, we are much higher than whether it is in Europe or in the UK. And if you look at complications, our complication rates are much lesser than what you would see in developed economies. And then finally, I think when we are able to, we also have to do something on the self-effectiveness. And we recognize that thinking beyond self will help you to be at one level, be content with what you have. And at the other level, you're constantly pushing the boundaries to become improve and become better. So it's not coming out of frustration. The push to become better comes out of contentment. So I think when we achieve this, I think we become quite effective as individuals. With this, I will stop and take questions if any. I'll just stop sharing.
Thanks a lot, Mr. Tulsiraj Ravila. So I think, Sam, you are on mute, Sam.
No, I really want to thank you and Sean for bringing, and Bala, this topic. I think what is interesting to me is that you took one little problem, which is a big problem, but when you look at water, sanitation, environment, power, telecom, all that, you took one little problem from health and made a huge impact. So my message to a lot of young people is that you don't have to boil the ocean. See, a lot of young people I talk to, they want to solve all world's problem, and in the process don't do anything. Here is a classical example of taking one little thing and make a huge impact. There are lots of little things like this around, where you focus on one vertical and then you go broad. And to me, this is the most important message. You really created a model that competed with the world, reduced cost, improved access, and made it affordable. I think affordable and sustainable go hand in hand. And you have shown how cleverly it can be done. So my compliments. Sorry,
Thank
Sean.
you, sir. Thank you.
There are a lot of kind of kudos for what you are doing from internet, from LinkedIn, multiple places. So I think amazing series of innovation and the reduction in cost by 10x is remarkable. I'm from Tamil Nadu, know that they are doing good vision, and the scale of operation is significant. Very effective interventions and insightful actions to ensure high success rates. Great initiative.
Thank you.
I think a lot of great positive feedback. Thanks a lot.
Thank you, everyone.
Are there any specific questions from Dr. Amalur Pavanathan or Bala to pick the brain of Mr. Tulasi?
I'm just amazed and dazed listening to this extraordinary achievement. Probably a role model for not just the country, for the whole world, where high quality need not be very expensive. It's actually, as one of my mentors said, good medicine is always cheap. It is only bad medicine which is costly. And you have proven to the world this simple truth, that good medicine need not be prohibitively costly. It can be affordable to the vast majority of the citizens of this world. This there are some similar experiments that readily come to my mind. One is the Cancer Institute at Adyar. Another is Sindh Institute of Urology and Transplantation in Pakistan, where anybody can walk in and have a transplant free. They need not pay. If they want to pay, they can pay in the cash counter later, but not before surgery. And it's one of the huge models in the world. And but such models are only few and far in between, and somehow not being able to be replicated by the state governments or the central governments at all. So, but I think the young doctors who are listening to this will choose their way. As one of my a plastic surgery professor told me that Amal, I have two ways. One is I can keep on doing beauty surgeries for actresses, or I can treat burns victims, and I choose the later. So I think if all doctors take up to this vision of serving the society for which their medical education was intended primarily to, we will see a better world. Thanks again for this amazing lecture. And I think every young aspiring doctor should see this and learn from this extraordinary and brilliant lecture. Thank you very much.
Thank you, Dr. Amalur Pavanathan. Bala, I have one question, then I'll give Sam maybe an update on what has happened globally last week on the American elections. Bala, where do you see Gandhi coming in this model? See, I think Aravind is phenomenal, right? So why they are a Gandhian change maker, you believe?
See, actually, this is a point where Peter Drucker, the management philosopher, and Gandhi come together. Peter Drucker, in one of his books, he says the purpose of an organization is to find out its consumer and fulfill its need at the lowest possible cost at the fastest mode, the easy accessibility. That it makes profits is incidental. It's saying when an organization goes around, identifying the problem of the consumer, goes around fulfilling at the lowest cost possible, then the profit is it is normal. It has to come, and the EBITDA of 29%, when we are comparing with the corporate hospitals, 12 to 14% is amazingly high. So when you drive behind profitability, you don't get profitability. You drive behind the fulfilling the need. In this case, the bottom of the pyramid, as Gandhi says, last man in the pyramid, which is who cannot afford. Somebody who was begging on the temple, as the first slide started. Their consumer is that. That is the last man in the pyramid. That is what Gandhi's principle also says. It's a brilliant presentation, Mr. Tulasiraj. I'm amazed, actually. I'm based. I'm going to reread this, almost like going through a lecture by one of the best professors on management, and it's
exactly,
amazing.
exactly, Bala. Really amazing.
Sir, I have a question.
Yeah, go ahead.
Can I just supplement? I'll do a quick supplement.
Please.
On the link with the Gandhian. I'm not an expert in the Gandhian philosophy, but I know that self-reliance was also core to the way Gandhi thought. And Dr.
Absolutely, sir.
He was a great disciple of Gandhiji. And then the notion of not taking donations actually came from that thought. Now, he actually said this verse. He said that I don't want EyeCare to my people be subject to the vagaries of somebody in Germany or USA giving us some donations. Our people can support it. And that's how this model evolved. So I think there is that. I think connecting the dots is getting a challenge. But then that thought that we have to be self-reliant. Again, making of the intraocular lenses locally again was spurred by that. Constantly depending on donated lenses or trying to bargain with them. And there was when they are not recognizing our needs, or our economy to make it affordable. So all of that, I think the self-reliance is possibly a one big factor, which resonates with Gandhian philosophy. Yes, Premada.
So firstly, sir, congratulations, and it's a remarkable achievement, like brilliant. So thank you for giving us this today's case study. My first question is, sir, how did you find any funding problems initially when you started this? And did you have any government support? And if someone wants, my second question is, if someone wants to replicate this model in another state, so how should we go about it? Like, suppose in a village or a small village in another state.
Sure.
Yeah, thank you.
Yeah. So in the early days, I think money was a problem because Dr. V was a government employee. He retired at a pension of less than 1,000 rupees. So there was no money. So initial periods, it was sweat capital. All of us took very little salary. I took a 75% cut in my what I was earning earlier. And then Dr. V and his close brothers and sisters mortgage their houses to get bank loan. Because in the 70s, banks took zero risk. So they would give money only when it was covered 2 or 3 times more than what they were lending. So the early days was tough. And that continued possibly for the first decade or so. But as the volume and the scale built up, we were able to slowly start paying market wages. So in my estimate, it took us about 15 years or so for us to actually start paying ourselves what was required, the more or less the market wages. And in terms of if others want to replicate this, we have a whole institute which does that work. And then we typically don't charge or request people to pay us because we're able to raise some grants to do that. So I just want to clarify. I said we don't take donations when you talk about grants. So we don't take donations for the core work, which is patient care and the training that goes to support the patient care. For all the other experimentation or research and helping other hospitals, we're able to we take grant money, and that's not been difficult to get. Because
Has anyone in UP and Bihar taken this?
Yes, sir. In fact, we are running we in fact set up 2 hospitals for Rajiv Gandhi Foundation.
That I know.
Amethi and Lucknow.
Yeah, that I know.
Which we are not managing now, but they still continue to do phenomenal work. Even today, we are actually managing the Sitapur Eye Hospital. Other than that, there have been half a dozen hospitals that we have mentored and helped to become more effective. This we have done for Bihar. Across the only states where we have not been active is Jammu Kashmir. Otherwise, every other state we have hospitals that we have helped.
Would you like to be active in Jammu Kashmir?
Certainly, sir. Certainly.
Okay, I'll talk to Abdullah.
Yeah.
I'll talk to
certainly.
Thank you, sir. Thank you.
A lot of people from different states are saying, I think you are doing great job in Assam, and I think somebody wants you to come to E-Road.
Good.
So I think without much ado, I'll give back to Sam. So Sam, do you want to kind of touch upon
No, I think we'll do it next time. This is such an interesting topic.
Shan,
I don't.
Shan, can I have just a point to make?
Yeah, sure, please.
Shan, no, this is, I have been observing the medical field for about 30 years. And the last 10 or 15 years, we see emergence of elaborate corporate sector in the medical field. Today, big corporate hospitals are no longer answerable to patients. They are answerable to their shareholders.
Absolutely.
The transcontinental flight of capital into these countries like India is phenomenal. It's in billions of dollars. The result is these big corporate hospitals absorb the best of the talent from the government sector and leave them high and dry. And this corporatization has also produced a very different culture that patients have to pay very high money and five-star type of suit and delivering births, etc. It's changing the culture of medical treatment in every branch of medicine except in ophthalmology. They failed totally in Tamil Nadu, probably because of an institution like Aravind Eye Hospital. The corporate sector could never penetrate ophthalmology in Tamil Nadu, probably because of the model put forth by Aravind Eye Hospital. This is my opinion.
Thank you. Thank you.
I agree with you 100%. I think it is not just a problem in health industry. It is also a problem in education. When I went to college
Yes, sir.
in 1950s, my tuition was 50 rupees. Now it is 50,000 rupees. So corporatization of education has also done the same thing. I think that's where the Gandhian thinking comes in. Decentralization, self-reliance, local talent, local capabilities, local solutions, affordability, sustainability. How do you get all of these things together? And it can only happen if you develop domain experts who are willing to give and not take. Like Mr. Ravela said, that they had to take less salaries in the beginning. It was a sacrifice. They made the sacrifice. How many people today are willing to make that kind of sacrifice for 10 years to serve people? I think that's Gandhian. Sacrifice is part of that Gandhian attitude. So ideally, we need to identify opportunities like this in health and education and environment. These are the three areas where we need to identify similar opportunities. Is knee replacement an opportunity? Is diabetes an opportunity? Is whatever, hearing an opportunity? So domain experts in health will have to say, I'll take these 10 verticals and do exactly what Aravind did. Then in education, we'll have to say, why does it cost 10 lakh rupees to get an MBA? I know I can get you an MBA for 5,000 rupees, guaranteed. It may not be exactly like Harvard or IIM. That's okay. Can it be 60%? 40% of that? With all the new technology and new tools, can I offer like MBA to all the MSME people? Saying you don't have to have a graduate degree to get an MBA. So I think these are the kind of things we need to really focus on. We are a very large country. Our needs are massive. I don't think India should focus just on bringing foreign capital and inviting all these multinationals. That's where we are different. And that's where we get beating also. Because modern generation doesn't understand that. They want to charge maximum for EyeCare and show it to their shareholder that we can give them better IRR. And we want to do exactly opposite to that. And that's the fight going on today in the world. What happened in US election is an example. Okay. Everywhere, rich are becoming richer and poor are remaining poor. Inequality has increased. That is the global challenge. And what Aravind has done is shown that there is a path forward. And I don't want to dilute this conversation today by talking about Trump or election. Okay. So I would just once again thank Mr. Ravila for sharing his slides and lifetime of commitment and experience. And I would encourage a lot of our young people to think about focusing on a specific area and really build expertise to solve a problem. And there are problems not just in health. There are problems in education, environment, employment generation, sanitation, water. There are lots of challenges. And only India can find scalable, sustainable solutions for the world.
Yeah,
True.
Not just for India.
True.
India is the workforce of the world. Nobody can produce the kind of workforce we produce. IT has shown that. Medicine has shown that. In America, there are 60, 50,000 Indian doctors who run American health system. If they stop working, the whole thing will collapse. I'm telling you. It's a very prominent role Indian medical graduates play. And they all got their education in India, funded by Indians. And that's India's contribution to America. No one looks at it that way. India has contributed tens of billions of dollars to America in the health sector. So, thank you again. Really appreciate and hope we can have more conversations like this.
Sounds good, Sam. Looking forward to meet all of you with a different topic next week. Thank you. Thanks, everybody.
Thank you, sir.
Thank you for this.
Thank you.
Thank you.
Thank you very much for this amazing opportunity to learn from Mr. Tulsi.
Thank you.
Thank you.
Thank you, sir. Thank you.
And if you know somebody like this, please bring them to our attention.
yes, sir.
Sure.
Because
Sure.
we don't know everybody.
Hmm.
We have limited knowledge. So if you know somebody is doing some great work like this, let's bring them on
Sure,
the
sir.
platform. Okay.
Yeah.
Thank you.
Yeah.
Thank
Sir.
you.
Thank you.
See you, everybody. Bye.
Thank you. Bye.
Thank you.
Bye.